Okay, girl. So I know that you have a lot going on today. I just wanna make sure that you're gonna be okay for this quiz on Wednesday. So I have been working on COPD through the ATI, just the ATI module, because that's what she told us to study. And I've been doing some of the simple nursing stuff, but anyway, I was copying pasting into ChatGPT and doing like a ton of quizzes and stuff. And this is like the study sheet that we came up with that I'm going to walk you through. Basically, the overview of COPD, this is chronic, meaning once a patient starts developing it, we can manage symptoms, but we can't cure COPD. But it's completely preventable. So the major cause of COPD is going to be like smoking. So when they say noxious gases and particles, think like, oh, this makes me so nauseated to smell cigarette smoke. It's noxious. I'm nauseated. You know what I mean? So when you see this word, think nausea because it's so disgusting. COPD is a chronic obstructive pulmonary disease. That's what it stands for. It's a mixture of two different disease states that occur, one being chronic bronchitis and the other one being emphysema. Additionally, we can have other diseases that can increase morbidity. So basically, like, how does this affect their life as well as how they die? So let's first talk about, before jumping into COPD, let's review the structures of the lung that are going to be affected. And I'm going to pull up pictures and we're going to talk about all this stuff a little bit more in depth. So, I don't know how to pronounce this word, asinus. I hope that makes you laugh. Okay, these words might be confusing. The asinus, asinus, I don't know, contains respiratory, just hear the words and then we'll talk about it. Respiratory bronchioles, alveolar ducts, alveolar sacs, alveoli. Before we look at pictures, basically what these things are. So you have let's take a look at photos now. You have like your lungs, right? So I like this photo. This is cool and dynamic. So here's your trachea. So this is inside of your throat, right? Like when we're palpating the thyroid, and it's like, oh, that's kind of where our trachea is. So there's your trachea. Just imagine that's your neck. This picture does not contain the actual lungs. It's just showing you. So basically, we have the trachea turns into, you have your main stem bronchi, and then you have your left bronchi and your right bronchi, right? These lobar bronchi, these little guys, this one is kind of what's going into the lung. These segmental bronchi are also going into the lungs. And then do you see how, as from the trachea to, this is called the bronchial tree, it just keeps getting smaller and smaller and smaller. So basically what they're saying over here with this asinus, there's these little terminal bronchioles. So these are going to be at the very end of this long bronchi tree. And they connect to these sacs called like alveoli. So terminal bronchiole is basically the air is coming in. This is where it stops before it starts to go into where we do gas diffusion. This whole thing, so this asinus, which has, I like that they kind of blew this up. So this is kind of like the terminal bronchiole here. These are all of our alveoles. All the alveoli. So even over here, we can kind of see like we have this terminal bronchiole. We have these little alveoli air sacs. So these are like units. That's all they're saying. This asinus is the terminal bronchiole, so these little guys, plus all of their airway sacs called alveoli. Now, the lung parenchyma, this is where it gets a little confusing, but just bear with me. The lung parenchyma is where we're going to have this bundle here, right? This bundle plus capillaries, which is like the capillary beds where oxygen gets exchanged with CO2, carbon dioxide. So, we have capillary beds around all of our tissues, all of our, um, it's where we exchange oxygen for carbon dioxide. And interstitium, which is going to be in between the tissue cells. So the lung parenchyma is not just this part. Oh, I actually really like this picture too. So here's our terminal bronchiole. This is our sinus or whatever. And then the parenchyma would be like, imagine you had a capillary bed like wrapped around these alveoli, right? Plus you have skin tissue, like you'd have an epithelial lining that's actually part of like the lung. So it's to think of it, the lung parenchyma is the functional part of the lung where the alveoli are kind of intertwined with the capillary beds so that they can exchange the oxygen for the carbon dioxide. That's what's going on. So that's what we're talking about here. So that's kind of our where COPD, the two disease states of emphysema and chronic bronchitis, that's where we're really imagining that the disease state is taking place, is in these kind of like, imagine a straw going into the middle of like a bunch of balloons, right? Like you have a bunch of miniature balloons and a straw going through the middle. That's basically what this is. And now imagine that bunch of teeny tiny little balloons with a straw is surrounded by like spaghetti that can like exchange materials between the little balloons and the hollow spaghetti. That's what we're talking about. So I know that sounds crazy, but that's basically it. Okay. So basically, a sinus, it's going to be the terminal bronchiole. So like the little plus the sacs. So this is our a sinus. And then the lung parenchyma is this a sinus with arteries and the veins that turn into capillary beds so that they can exchange oxygen with CO2 and then breathe it out. Okay. So your alveoli, basically in order to keep your lungs inflated and healthy, there's this substance called surfactant. And it will be important to know this. It's a complex mixture of fats and proteins produced by alveolar cells. Forget the type 2 for now. It significantly lowers surface tension. So this is important because you don't want those alveoli to collapse upon exhalation. So the surfactant keeps the alveoli alive. So that surfactant does have some, also your lungs have elasticity, right? Because they have to expand, they have to collapse. So we're just going to talk about the actual structural changes of COPD. This includes loss of that elastic lung recoil. So it's harder to expand and it's harder for them to relax. So think of a balloon. Like if you put a balloon in the freezer, it would be really hard for that balloon to expand and contract, right? Think about it like that. Airway inflammation. That basically means your trachea into your little bronchioles. Remember those bronchioles? Let me go back. These guys, they become inflamed. Fibrosis, scarring. So, think about someone who's like coughing a lot, or someone who it like any organ that would get fibrosis from misuse, you know? So all those like bronchioles in your lungs, they're developing scar tissue. Airway narrowing, this happens from all of these things plus mucus happening together. The airway narrowing occurs from airway inflammation, fibrosis, mucus production, which we'll get into. Now, because chronic obstructive pulmonary disease, it is an inflammation of your airway. When we have inflammatory states, it's going to excite certain immune cells. So it's going to excite T lymphocytes that are going to come in, and they're trying to basically just clean things up. It's going to excite the neutrophils, who are also going to try to clean things up, as well as macrophages, which are they're going to eat up. They're trying to eat all the bacteria and the mucus. They're trying to eat up all the toxins and get rid of it. So these are the 3 inflammatory cells we should really know are part of COPD. We talked earlier about how COPD is a mixture of bronchitis and emphysema. Chronic bronchitis is a mucus problem. If you remember anything, just remember it's a mucus problem. The diagnostic criteria, the patient has to have a productive cough, meaning they're coughing up mucus for 3 months out of the year. So that would be like January, February, March. 3 months out of the year for 2 consecutive years. Or it could be October, July, and September for 2 consecutive years. So 2 years in a row, they need to have 3 or more months where they're coughing up sputum or mucus. What happens in chronic bronchitis? So imagine someone is smoking, right? They're like, even when I was a smoker, I used to like cough a lot and I'd have a lot of mucus. I was a pretty heavy smoker, especially when I started vaping. So that's when it became like, wow, I have a lot of mucus going on here. That's because it's your body, your lungs are basically increasing the amount of like mucus producing cells so that they can try to capture those toxins and have you cough it back up. That's the point, is to get it out. So you have a lot of mucus happening, right? It's a mucus problem. Increased goblet cells and increased mucus glands. So both of these types of cells, let's take a look at these. Let's take a look at goblet cells and what they do. These guys, I'm pretty sure they produce mucus. So let's take a look. Specialized cup-shaped epithelial cells found lining the respiratory and GI tract. Their primary function is to synthesize and secrete gel-forming mucins, which combine with water create protective mucus. Okay, so look, we have increased goblet cells. What does that mean? Increased mucus production. Increased mucus glands. What does that mean? Increased mucus. So that's what's going on. Now, when you're breathing in smoke, because these chemicals, they create inflammation through a lot of complex biochemical binding pathways. Like when we were in chapter 2 of patho, and it was talking about like oxidization and all that and free oxygen radicals. All you need to know, inflammation happens from those complex pathways, right? Because think about the chemicals that you're breathing in with a cigarette is combining with the chemicals like oxygen and CO2 that are already in your body, right? And they're going to make your cells, including like the macrophages, including your inflammatory cells, react differently. It's going to make them react differently, and things are going to get inflamed. these inflammation and mucus is going to cause airway narrowing, right? This is all progressive, leading to airway narrowing. So now what happens is we're overwhelming the body, right? We're overwhelming our body. We're overwhelming these guys. They have too much work on their hands. They're like, whoa, there's so much mucus. There's so much inflammation. There's so much narrowing. The body can't function in COPD and chronic bronchitis. It's not functioning properly anymore. So what ends up happening, the macrophages, who they're trying to clean up the bacteria, they're trying to clean up the toxins, they can't keep up anymore. They literally get damaged. So what happens? You have an increased infection risk, because think about all that mucus you're producing is also going to attract bacteria. And if you don't have the macrophages to be cleaning up that bacteria in your lungs, you have an increased infection risk. They can't do their jobs. They're overwhelmed. Bacteria build up. Boom, infection. The most common causes of chronic bronchitis: active smoking and secondhand smoke. Easy. If anything, just remember, bronchitis, it's a mucus problem. Okay, let's move on to emphysema. It's a destruction problem. So we kind of touched on this earlier. Basically, what happens, the big picture is you have a permanent enlargement of the air spaces. So let's go back to our picture of alveoli, ravioli, right? These things basically get destroyed. So it's basically like this. It's just like an open space where air can literally get trapped. This happens through destruction of the walls of these little balloons over here, right? And what happens when these little balloons, which basically, think of our lungs, they're made of the millions of these little balloons, you're going to have an airway collapse. Air literally cannot get through. It's just trapped in your lungs. If there's no way to get back into, this trachea to go out, it's trapped. So you have airway collapse. Loss of elastic recoil, meaning the lungs, they can't expand. That balloon, it can't expand. Loss of capillary bed, that's bad, because those capillaries, which are exchanging oxygen for carbon dioxide, they're gone. So you can't get that waste out. The CO2 just builds up. The air gets trapped. The CO2 builds up. And you can have moderate to severe airflow obstruction because the air is literally trapped. Most common causes, guess what? Cigarette smoke, noxious gases. So emphysema is a destruction problem. These little balloon sacs get destroyed, trapping the air. Capillary beds are destroyed, meaning there's no exchange of waste product of carbon dioxide going back out. Mix it with a mucus problem, you're in trouble. Okay, still talking about emphysema. So there's 3 different types, and we won't go into a lot of details because all you need to do is try to remember. Proximal, think close to smoke, and coal miners. So proximal means you're nearby. Proximal, situated closer. Leave it at that. You're situated closer to the smoke and the coal. Proximal, smoke, coal. You're close to the smoke and the coal. Panaciner. Think pana-anti. So this is emphysema associated with an alpha-1 antitrypsin deficiency. If you can just recognize the anti part and tie it to the pana part, just think pana-anti. Pana-anti. This is a genetic thing. We won't go into it. Distal, pneumothorax, associated with spontaneous. These are just things you just have to memorize. So we'll do it again. Proximal, close to smoke and coal. Pana-anti, pana-anti, pana-anti. Panacine is associated with alpha 1 antitrypsin deficiency. Distal pneumo, distal pneumo, distal acinar associated with spontaneous pneumothorax. Just need to repeat it over and over again. Risk factors for COPD. Females have a higher risk of developing it than males. Tobacco smoking increases your risks for developing COPD. Increased airway. So if you're like super allergic, like think about me when I eat dairy and my airway closes up, or let's say like if you have seasonal allergies, that can make you at a higher risk for developing COPD. Environment or occupational dust and fumes. So think about like a firefighter, right? He's at a higher risk for developing COPD. Mild to moderate persistent asthma. Think about airway inflammation, mucus production, chronic bronchitis, emphysema, airway destruction, chronic lung disease. Anything that is going to basically change how your lungs function, including apparently being a good girl. Whatever. COPD in developing countries, the most common cause is biomass fuel exposure. So biomass fuel exposure, let's just take a look real quick. Inhaling toxic smoke from burning materials like wood, crop residue, and dung. Okay, so that's really similar to environmental occupational dust and fumes. All right, here's where we're going to get into how do some of these comorbidities really impact how a patient kind of lives their life with COPD. As with COPD, everything's going to get worse. Your mortality, so your chance of dying increases. Your exacerbations of having like a lot of coughing or like episodes of really bad disease increases. Your symptoms are worse and your quality of life is lower. So think about this just from a rational, logical perspective. If you have asthma, so you already are reactive in your airway, plus you have COPD, which is a mucus problem as well as an airway destruction problem, good luck, man. Like, literally, I don't know how you're going to survive that. If you can't breathe, and then on top of it, you've already got breathing problems, good luck. So, asthma, COPD, everything's worse. And anything that sounds bad probably contributes. Common comorbidities. So, cardiovascular disease. Think about, cardiovascular disease mostly happens through what we just studied, development of atherosclerosis, which is directly related to dyslipidemia, right? So if your arteries, meaning also your capillary beds, if your blood flow is screwed up, you can't exchange, even in your lungs, that blood is still flowing through your lungs to get the CO2, exchange it for oxygen. And if you don't have that blood flow, because, your heart is not able to do its job as well, that's really, that's going to be easily a comorbidity with COPD. That makes a lot of sense. Hypertension, that makes a lot of sense, right? Because we're thinking the gas exchange of oxygen and carbon dioxide occurs through the blood flow as it's going through the capillaries around our little balloons, around our little alveolar balloons, right? They're interacting, the capillaries are surrounding these, and they're exchanging CO2 with oxygen. If you have hypertension and your blood flow is messed up, that's really, think about how that would impact the exchange of oxygen and carbon dioxide around your little balloon lung sacs. Respiratory bronchiectasis. That's like a collapse of your bronchi. Yep, that makes sense why that would be commonly associated with COPD, because the disease state just destroys your ability to breathe normally. Also comorbidities, anxiety, depression, mental health stuff. I mean, if you can't breathe properly, that's going to really screw with your head. These are just some quick facts. Epidemiology. The global prevalence of COPD is 10.3% worldwide. So there's a 10.3% occurrence of it currently right now. Men, all right, this was confusing. Men have a prevalence of 11.8%. Now, I know you're saying, well, I thought females were more at risk. There's a difference here. Men across the board have higher levels of having developed COPD than women. Women still have more, it's a higher risk. If you're a female, you're just more at risk for developing this as a disease. Whereas, men, due to lifestyle, drinking, smoking, jobs, they develop it more than we're going to see in the female population. Women have an 8.5% occurrence of developing it. The highest prevalence of COPD in adults occurs over 60 years. So age is a big factor here. The older someone is, the higher their chance of developing COPD. So a good question would be, out of 4 different age groups, who has the highest chance of developing COPD? You have a 6-year-old, you have a 24-year-old, you have a 55-year-old, you have a 70-year-old. The 70-year-old has the highest chance of developing COPD. It is the 3rd leading cause of mortality and morbidity worldwide. This is important. Learn this one, if anything. Not so important. Okay. This is important. We need to know, what does COPD look like? Early manifestation is exertional dyspnea. What does this mean? You're walking up a flight of stairs and someone's having a hard time breathing. You're literally just walking around in the grocery store having a hard time breathing. That's all it means. If you are doing an activity that normally a normal person, a normal assuming person, doesn't necessarily cause them problems, like walking up the stairs, walking around the grocery store, walking around the mall, but someone who has COPD, that's a lot for them, and it makes it hard for them to breathe. Common manifestations of early manifestations for COPD: dyspnea, so hard to breathe; chronic cough, right? That makes sense. We have to have, for 2 years, 3 months of consistent sputum productive coughing, right? Sputum production, so that's our mucus production; wheezing, so that's that hard to breathe; and chest tightness. So all in all, just think hard to breathe, mucus, cough, right? Now, this is later stages. So as someone who's had COPD for a while, like 10, 15 years, right? Barrel chest. Remember that from physical assessment when we were like looking at the rib cages? Pursed lip breathing. So they're like they're making that kissy face and they're trying to breathe. Accessory muscle use. So like using the sternocleidomastoid and the neck, using rib cage muscles. Now, Hoover's sign, this is a breathing thing, but I do want to look it up because Hoover's sign, what is that? One use neurology, COPD. Paradoxical inward movement of the lower rib cage during inspiration. Okay, so your lower, the very low rib cage part, when you breathe in, it goes inward. It collapses inward. That's the Hoover sign. Neck vein distension, so JVD, right? Our carotid arteries in our neck, they're going to be like those neck veins are going to be distended. They're going to be thicker. Decreased breath sounds. That makes sense. In your lungs, you're not going to hear as much good breathing because you don't have as much air to breathe. Crackles, wheezes, you're going to have buildup of mucus, which is like, if you think of like a bog from like a cartoon, it's like pop, pop. Tripod positioning, because the person's trying to breathe easier. So that means they have their feet flat and they're just leaning over. They're supporting their upper body by putting their weight on their elbows. Let's just look at it. Yep, just like that. Okay. What does a COPD exacerbation look like? You're going to have a lot of trouble breathing, high volume And what the heck does purulence mean? A lot of containing or discharging pus. So you're gonna have bacterial infection. Okay. So this is what a COPD exasperation. Just think, hard to breathe, and they have a lot of crap coming out their mouths. They have a high volume of it, and they are discharging it, and it's foul. Ugh, gross. Okay. When we are diagnosing COPD, we are mostly using a spirometry, which is the cornerstone of diagnostics. So that's the thing we breathe into. The gold airflow limitation ratio is a forced expiration volume versus forced vital capacity. So explain FEV1. Forced expiratory volume in 1 second. It's the volume of air you can forcefully blow out of your lungs in a single second after taking a deep breath. So literally taking a deep breath, you give yourself 1 second, right? Explain FVC. Forced vital capacity. You can forcefully exhale from your lungs after taking the deepest breath possible. You take a deep breath, and then you blow it out. Now you're asking, what's the difference? That's a great question. Difference between Okay, so the difference, they're really basically so similar, except FEV1 is just how much air you can blow out in the first second. Other diagnostics. So this little one, first second. But this is important to know. We're going to use a spirometer to measure this. Other diagnostics: pulse oximetry, oxygen saturation, chest tomography, and a chest x-ray, right? We want to see what we're looking at. What does it look? Computated tomography and a chest x-ray. We want to see the inside of the lungs. What are we looking at? Nursing. This is where we come in. What are we assessing, right? We start with assessment. We're going to do a pulse ox. We're going to ask them about their smoking history. We're going to check out how much mucus they're producing. We're going to listen to their wheezing, breathlessness. We're going to see how they're doing with this, just like watching them, observing them. We're going to maybe ask them to walk around the office a little bit and see if they can breathe. We're going to observe if they're using accessory muscles, and we're going to see if their body is blue. Right? We want to look for signs of lack of oxygen, which include cyanosis, which is a blue body. When we are doing our assessments and we're gathering information, we want to test respiratory effort. We want to listen to lung sounds, right? To hear wheezing or breathlessness. We want to get their pulse ox to see how much oxygen their red blood cells can carry. Ooh, look at this. Nursing intervention. Super important, right? What do we want to do? We want to improve oxygenation. So we're going to administer oxygen as ordered. We're going to instruct them how to do pursed lip breathing. We're going to elevate the head of the bed. We're going to promote them to rest and administer medications as prescribed. Now, why do we encourage pursed lip breathing? It helps you control SOB, release trapped air in the lungs, and slow your breathing rate. Patient education. Gotta stop smoking. Preserve your energy. Different breathing techniques like pursed lip breathing. We can recommend them to a pulmonary rehabilitation person. We can teach them to recognize symptoms where they need to call their provider, and teach them to avoid, environmental irritants. or, occupational hazards. Smoking cessation timeline. So when someone stops smoking, after 1 week, they have an increase of oxygen and carbon dioxide normalizes. This means breathing is going to become easier and it's going to become cleaner. After 1 month, they can walk easier. They can go up the stairs more easily. Their cough decreases. Congestion decreases, so that mucus production decreases. Circulation improves. And I can actually attest to this. When I was really heavily smoking and I stopped, my skin tone was really screwy. It was so pale when I was smoking because I literally was smoking so much. I wasn't getting oxygen. So after 1 week, I do remember being like, I feel like I'm breathing easier. And after a month, I was like exercising better. Like I genuinely felt better. And within a year, I felt like a new person. Like it was crazy. I was able to exercise for longer periods of time. I actually felt like the air I was breathing was cleaner. I don't have mucus production anymore. Like I was having a lot of mucus production. It was gross. And I just don't have those. Like it was like when I talked, like you could hear like the mucus in my throat. It was gross. Long-term respiratory illness risk decreases. Comorbidity complications decrease and quality of life improves. Vaccines that are important for COPD clients. They should all be getting their flu vax. For clients who are over 65, let's look up what the hell these freaking things are. Okay. 2 distinct vaccines used in a 2-part series to protect against. All right, so PCV13, which is this top one, is the pneumococcal conjugate vaccine. Protects against 13 types of pneumococcal bacteria. PPSV23 is a pneumococcal polysaccharide vaccine that protects against a broader range of 23. So this one, 13 types of pneumococcal, so think pneumonia bacteria. This one protects against 23 versions of pneumonial bacteria. And anyone who's over 60, they should be getting RSV vaccine. COPD medications. SABA rescue. So like that albuterol, that's like what you take when you're having an asthma attack or COPD. It's immediate symptom. LABA, this is the long term. This is what a lot of people are given, prescribed when they're diagnosed as a LABA and a LAMA. Antimuscarinics. So we have ipratropium, tiotropium. They block muscarinic receptors. Muscarinic receptors are found on smooth muscle and especially like in the lungs. They are what things can bind to like adrenaline or histamine, right? They can cause bronchoconstriction, so that's a problem. I think M3 are mostly, let's see, M3, what do M receptors bind to? Neurotransmitter acetylcholine to trigger parasympathetic responses. Okay, airway bronchoconstriction. So they cause bronchoconstriction. Okay. So we don't want bronchoconstriction. So we want to block these receptors. And that's what these things do. And LAMA is used as maintenance therapy. So the first line of COPD maintenance, LAMA, LABA. LL. Theophylline is used if these two things are not working. So it's basically what these do, they relax smooth muscle and they help mildly dilate your bronchi. So they open up your airway. But these are used after first line is not working anymore. Corticosteroids used to decrease inflammation, decrease mucus production. Medications, I think these would be used like very, very last in line, right? Because think about steroids, what we've learned about, which is they suppress your immune response. So that's not good. They can cause like Cushing's or, if you have too many steroids or too little steroids. Medication side effects, bronchodilators, trembling, headache, dry mouth. That's just something you just got to memorize. Bronchodilators are going to cause trembling, headache, and dry mouth. Corticosteroids are going to cause weight gain, diabetes, osteoporosis. So remember when we were learning about steroids and how it kind of keeps blood sugar high because your body's like, I need energy, I'm in fight or flight. So you're going to have weight gain, which is going to then, because you have so much sugar in your blood, lead to diabetes, osteoporosis, because bones are becoming less dense. All right. ATI's 4 favorite medication questions. SABA, rescue. Albuterol is a SABA rescue. LABA, long-term control. Antimuscarinics, block M3. So M, think M, right? Epratropium, tiotropium. Those are antimuscarinics. First-line maintenance therapy is LAMA and LABA. And that is my quick review for you.